So normally, now what we are seeing over here, it is one of the part of the vessel. This is the tunica media. Okay, over here we are looking at the media, and the tunica media, they are containing the elastin fiber. Okay, the elastin fiber, if you see, which is shown in black over here, usually there is one stain that is called as the Mowat stain, which is highlighting the elastic fibers, and the elastic fibers are showing black in this particular staining. Okay, so normally if you look at the tunica media of the vessel wall, okay, they show a regular layered pattern of elastic tissue, as you can see. So you can see these are elastic tissue or elastic fibers. You can see how they are regularly arranged one top of each other. This is a normal arrangement of the elastic fibers in the tunica media. But in case of aneurysm, okay, in case of aneurysm, what you are going to see, if you look over here, this is the part that has been involved. What you see over here, that there's a marked elastin fiber fragmentation disarray is there. And because all these elastic fibers are getting degenerated, you are having a lot of cystic spaces that is created. So these are the cystic spaces that is created, and these cystic spaces, they become filled with a basophilic, mucinous material that is called as proteoglycans. Okay, so areas devoid of elastin fibers, they form cystic spaces, but it becomes filled with the proteoglycan. This is called as the cystic medial degeneration, as we can appreciate over here. This is a patient of Marfan syndrome, and over here such kind of cystic medial degeneration can be appreciated. Okay. Myself, Dr. Jibran Ahmed, presents to you Simply Pathology, and today we are back with an important session. Today, as you can see the thumbnail, we are going to discuss about aneurysms and dissection. So basically, before we start our topic of discussion, first I would like to read out some of the important clinical case scenarios so that you understand that how a patient of aneurysm or dissection presents. So basically, a 62-year-old man presents with a 2-week history of abdominal discomfort. Physical examination is revealing a pulsatile abdominal mass in the periumbilical region. A CT scan shows a segment of abdominal aorta proximal to the bifurcation that is dilated around 5 centimeters and also calcified. The patient is scheduled for corrective surgery but suffers a massive stroke and expires. Now the abdominal aorta is examined at autopsy and shows a large mural thrombus within the lumen. Which of the following is the most likely underlying cause of the patient's abdominal mass? Okay, so we will address this question at the end of this session after we complete discussion on aneurysm as well as dissection. Okay, so I want to make it clear that how do you differentiate between aneurysm as well as dissection? How do you differentiate between these two conditions? Okay, I will discuss all the important points and I will tell you how to differentiate the two conditions and how to answer in the exam. So this is the first important MCQ. The second important clinical case scenario is a 58-year-old man with a history of hypertension and type 2 diabetes mellitus is rushed to the emergency room after collapsing. Now he describes a tearing chest pain radiating to the back. His blood pressure is falling and it is 90 by 50 millimeters of mercury and pulse is diminished. Cardiac auscultation reveals a diastolic murmur consistent with aortic regurgitation. The ECG is normal and blood test for cardiac specific proteins and enzymes are negative. Okay, that means, okay, we have ruled out myocardial infarction. Yet the patient dies within 24 hours of admission. The thoracic aorta at autopsy shows a sharp transverse intimal tear. The pathogenesis of this lesion is most closely related to which of the following underlying condition? Okay, so we are also going to discuss this, at the end of this particular session. So stay tuned till the end. So first we are going to read about aneurysm. So what is an aneurysm? What is the definition? An aneurysm, it is a localized and abnormal dilatation of a blood vessel or the heart that may either be congenital or acquired. How do you classify aneurysms? Now aneurysms can be of two types. They can be true aneurysm or they can be false aneurysm. So always remember that whenever the aneurysm is involving all the layers of an intact either arterial wall or the ventricular wall of the heart, okay, then it is called as a true aneurysm. So in the true aneurysm, there is really dilatation involving the layers of the arterial wall or the heart, but the condition is that the layers should be intact. There should not be any compromise in the layers, okay. So all the layers has to be intact. So what are the examples of a true aneurysm? So atherosclerotic aneurysm, congenital vascular aneurysm, or ventricular aneurysm following transmural MI. What is the meaning of transmural? When all the layers of the heart, okay, are showing ischemia, or there is an infarction involving all the layers of the heart. So with the help of this diagram, I am going to show you, okay, with the help of this diagram, I am going to elaborate my point. So this first two diagrams, as you can appreciate, both these diagrams are showing a true aneurysm wherein there is a dilatation, but the vessel wall is intact. There is no compromise in any of the layers of the vessel wall. So you know, I appreciate that if you know and if you remember that what are the layers of the vessel wall? We have the tunica intima, then we have the media, then we have the adventitia on the outer aspect. Okay, so these are the three important layers of the vessel wall. Now we are discussing over here true aneurysm. Okay, so we have already said that aneurysms can be of two types. One is the true aneurysm, one is the false aneurysm. First we are discussing about the true aneurysm. Now true aneurysm on itself, they can be further subdivided into two types. One is the saccular variety, one is the fusiform variety. So the saccular variety of true aneurysm is an aneurysm when the vessel wall focally bulges outward. So only at a particular focal point, okay, like we can see over here. So when the vessel wall is only focally dilated. So when the vessel wall is focally bulging outward as a spherical outpouching, we call it as a saccular aneurysm, which is a type of a true aneurysm. It involves, as I have said, a portion of the vessel wall. Only a portion of the vessel wall, as you can see over here, has been involved. Now, in intracranial vessel, the size or the diameter ranges between 2 to 20 millimeters, whereas in the aorta, it can range from 5 to 10 centimeters in diameter. And this kind of, saccular aneurysm, they might contain thrombus as well. Now, remember, any aneurysm can contain thrombus. Okay, remember that point. So aneurysm or any abnormal dilatation, they can contain thrombus. Okay, so this is about the saccular variety of true aneurysm, wherein the vessel wall is only involving a portion of the vessel and vessel wall shows focal bulging, as we can appreciate over here. The next type of true aneurysm, that is called as a fusiform. As you can appreciate, in the fusiform, there is a diffuse circumferential dilatation. So there is a diffuse circumferential dilatation of a vascular segment. It involves the aorta, wherein the size ranges between 5 to 10 centimeters in diameter. It may involve the aortic arch, abdominal aorta, as well as the iliacs. Okay, so these are the two important varieties of true aneurysm. We have the saccular as well as the fusiform variety, which are examples of true aneurysm. Okay, so we have already seen, okay, about the true aneurysm, the condition being that the vessel wall should be intact. So there is a dilatation, but the vessel walls are intact. Now we want to understand what is a false aneurysm. It is also known as pseudoaneurysm. So it is a defect in the vascular wall leading to extravascular hematoma, okay, that freely communicates with the intravascular space. In that case, it will be pulsatile and we will call it as a pulsatile hematoma. I will repeat. A false aneurysm, also known as a pseudoaneurysm, it is a defect in the vascular wall leading to extravascular hematoma that is freely communicating with the intravascular space. So the difference is, in the false aneurysm, there is a compromise or a defect in the vascular wall, whereas in the true aneurysm, the vascular wall is intact. So what are some of the examples that we see for false aneurysm? Whenever there is a ventricular rupture after myocardial infarction, which is contained by pericardial adhesions. So remember, if for example this is the heart, okay, and if there was an ischemia, suppose this portion, but this portion, okay, because of ischemia has dilated, but the wall of the heart is yet intact in this part, then it will be called as a true aneurysm. But suppose there is another condition, this is the heart and there is rupture of the ventricle, okay, for example the ventricle has completely ruptured over here, okay, and what has happened, whatever blood was there, it has come out, okay, but it has not come out of the heart because the pericardial protective layering was there. So for example, over here the dilatation is there, but the dilatation has been stopped by a pericardial adhesion, by a pericardial covering, and not by the covering of the ventricle. Then this is called as a false aneurysm. Okay, so the example is ventricular rupture. When there is a ventricular rupture, the ventricle has completely ruptured, and after that there is a hematoma, there is a collection of blood, but that has been contained by the pericardial adhesion. Okay, this is a false aneurysm. Okay, or whenever there is a leak at the sutured junction of a vascular graft with a natural artery, it is also called as a false aneurysm. So to give you an example with the help of this diagram, as you can appreciate, so over here you can see that there is a compromise, there is a defect in the vascular wall, okay, over here, and whatever blood was there, it has basically extra was there, it has gone out. Now it has been stopped, by extravascular connective tissue. So you can see in black I have shown the extravascular connective tissue, and this localized collection of blood, this is called as a hematoma. So there is a formation of a hematoma over here, okay, and the containment is not by the vascular wall, rather by the extravascular connective tissue. So this is called as a false aneurysm, also known as a pseudo aneurysm. So I hope this concept is very clear to everyone. Okay. Now, having discussed about the different types of aneurysm, we are having true aneurysm, which can be fusiform or saccular, and then we have false aneurysm. We have discussed about the examples as well. Now over here we are going to discuss the basic pathogenesis of an aneurysm. So remember, normally in the arterial wall there is a constant amount of remodeling. That means there will be synthesis, degradation, repairing the damage to the extracellular matrix component. So normally the extracellular matrix component will constantly synthesize, will degrade, will also keep repairing their components. Okay, if the structure and function of the extracellular matrix is altered, it can lead to aneurysms, and aneurysms can either be sporadic or it can be heritable. I will discuss all the conditions. First, let us try to understand the basic pathogenesis. So the basic problem is that there is a structural or functional alteration of the extracellular component, okay, in case of aneurysm. The first important point in the pathogenesis is the poor quality of the vascular wall connective tissue. For example, in case of Ehlers-Danlos syndrome, in the vascular form of Ehlers-Danlos syndrome, there is a defective type 3 collagen, which is one of the components of the extracellular matrix. Because of the defective type 3 collagen, there is a weakened vessel wall. That is why it gives rise to aneurysm. So this is the hallmark feature of the vascular form of Ehlers-Danlos syndrome, which is one of the heritable conditions. Okay. The second important point in the pathogenesis is when there is an abnormality in the TGF-beta signaling pathway. So always remember, excessive or increased TGF-beta signaling or excessive amount of activity of the TGF-beta, it alters the vascular wall, leading to vascular wall remodeling. Okay, and ultimately what happens because of this excessive TGF-beta signaling accompanied by altered vascular wall remodeling leads to reduced amount of extracellular matrix component inside the vessel. That facilitates the aneurysmal dilatation. So what is the example of this particular point? For example, in case of Marfan syndrome, there is a defective synthesis of fibrillin protein, and because of the defective synthesis of this fibrillin protein, there is inability to properly sequester TGF-beta. As a result, more amount of TGF-beta is available. So excessive TGF-beta signaling will be there. That will lead to altered vascular wall remodeling. That will lead to reduced ECM component, and ultimately there will be aneurysms in patients of Marfan syndrome. Similarly, there is another condition that is called as Lewis-Diet syndrome. Over here, there is a mutation affecting the TGF-beta receptor. Again, because of this mutation, the same thing, there is an excessive amount of TGF-beta signaling, and because of the excessive TGF-beta signaling, there will again be alteration of the vascular wall, remodeling, leading to reduced amount of ECM components, and as a result, ultimately aneurysmal dilatation will be there. But in this particular case, the aneurysm here, they can rupture at small sizes. Therefore, they follow a very aggressive course. So this is the second point in the pathogenesis, abnormality in the TGF-beta signaling. The third important point is balance between the collagen degradation and synthesis is altered by inflammation. So inflammation also is playing an important role in the pathogenesis of aneurysm. So basically, in conditions of aortitis as well as in conditions of atherosclerosis, there is an excessive amount of inflammatory cells in the vessel wall. So macrophages and other inflammatory cells, they lead to an excessive amount of MMP production. What does MMP stand for? They stand for matrix metalloproteases. So MMP stands for matrix metalloproteases. As the term suggests, these are proteases. So basically, what does MMP do? They degrade the extracellular matrix protein, and that facilitates the weakening of the vessel wall, leading to aneurysm formation. I will repeat once again, in any condition of inflammation, there are lots of inflammatory cells, okay? And all these inflammatory cells, especially the macrophages, they release matrix metalloproteases, which is degrading the extracellular matrix protein, leading to weakness of the vascular wall, facilitating aneurysm development, okay? Not only this, always remember that in such conditions, there can be sometimes any condition where there is a genetic predisposition to aneurysm in the setting of inflammation may be due to either MMP polymorphism or TIMP polymorphism. Also remember one thing I forgot to tell you, excessive amount of MMP production can lead to aneurysm. Similarly, remember in our body there are certain inhibitors of MMP, that is called as tissue inhibitor of matrix metalloproteases, called as TIMP. If there is reduced activity of TIMP, that might also facilitate aneurysmal development, okay? Any condition when there is a genetic predisposition to polymorphisms, genetic predisposition to aneurysm can be there in case of MMP or TIMP related polymorphisms, okay? Now, abdominal aortic aneurysm, in that case, it is associated with a shift in the local cytokine environment, okay, towards production of Th2 cytokines, that is interleukin number 4 and interleukin number 10, which stimulates the macrophages, which causes excessive release of MMPs, facilitating abdominal aortic aneurysm, okay, in this particular case. So this is how inflammation is playing an important role in the causation of aneurysms, okay. So excessive MMP reduced TIMP is very important. In certain cases, there is a shift towards production of T helper 2 cytokines, that is interleukin 4 and 10, which stimulates the macrophages to release the MMPs, as in case of abdominal aortic aneurysm. The fourth important point in the pathogenesis is the vascular wall is weakened through loss of smooth muscle cells or because of an inappropriate synthesis of non-collagenous or non-elastic extracellular matrix, okay. Remember one thing, that as in case of atherosclerosis, if you see, in atherosclerosis there is inflammation that is playing a role, okay. Secondly, in case of atherosclerosis there is a thickening of the intima. Now for example, if this is the adventitia, this is the media, okay, and over here is the intima. Now normally the intima is thin. Now in case of atherosclerosis, what might happen, that basically the thickness of the intima might increase. Therefore, more amount of distance, now the oxygens and the nutrients have to travel to supply oxygen to the media. So what happens, that atherosclerotic thickening of the intima can lead to ischemia of the inner media, okay. Similarly, systemic hypertension can cause significant narrowing of the arterioles of the vasa vasorum. Now what is the vasa vasorum? Vasa vasorum is arteries which are supplying arteries. They are called as vasa vasorum. Okay. See, arteries normally they are supplying other organs in the body, but there must be some, artery which is supplying an artery. So an artery supplying an artery is called as a vasa vasorum. In conditions of systemic hypertension, there can be significant narrowing of the arterioles of the vasa vasorum, ultimately leading to the outer medial ischemia can be there in case of systemic hypertension, leading to aneurysms. And in case of tertiary syphilis, if you see, there is obliterative end arteritis. There is an inflammation of the end arteries in the vasa vasorum. So again, the vasa vasorum is involved in tertiary syphilis. There is an obliterative end arteritis in the vasa vasorum of the ascending aorta, especially the ascending aorta, leading to medial ischemia. Okay, so in all these three processes, as you can appreciate, there is a weakening of the vascular wall. There is a weakening of the vascular wall, which is due to the medial ischemia. Okay, in all the above processes that we have read, in all the four processes that we have seen, there is a histopathological change in the arterial wall, which we call it as medial degeneration, cystic medial degeneration. It is a common non-specific finding which is seen in all forms of aortic disease. Okay, in all forms of aortic disease you will see this cystic medial degeneration. Let me show you with the help of a diagram over here. So normally, now what we are seeing over here, it is one of the part of the vessel. This is the tunica media. Okay, over here we are looking at the media, and the tunica media, they are containing the elastin fiber. Okay, the elastin fiber, if you see, which is shown in black over here. usually there is one stain that is called as the Mowat stain, which is highlighting the elastic fibers, and the elastic fibers are showing black in this particular staining. Okay, so normally if you look at the tunica media of the vessel wall, okay, they show a regular layered pattern of elastic tissue, as you can see. So you can see these are elastic tissue or elastic fibers. You can see how they are regularly arranged one top of each other. This is a normal arrangement of the elastic fibers in the tunica media. But in case of aneurysm, okay, in case of aneurysm, what you are going to see, if you look over here, this is the part that has been involved. What you see over here, that there's a marked elastin fiber fragmentation disarray is there, and because all these elastic fibers are getting degenerated, you are having a lot of cystic spaces that is created. So these are the cystic spaces that is created, and these cystic spaces, they become filled with a basophilic, mucinous material that is called as proteoglycans. Okay, so areas devoid of elastin fibers, they form cystic spaces, but it becomes filled with the proteoglycan. This is called as the cystic medial degeneration, as we can appreciate over here. This is a patient of Marfan syndrome, and over here such kind of cystic medial degeneration can be appreciated. Okay, now we are going to see the different kinds of etiologies which is responsible for aneurysm, and actually these are causes. Okay, these are causes which are actually leading to weakening, okay, which is leading to weakening of the vessel wall. Okay, weakening of the vessel wall. So the most important cause of aortic aneurysm, there are two most important causes. Number one is atherosclerosis. Remember, atherosclerosis, it is the most important cause of abdominal aortic aneurysm. It is playing a very important role in the pathogenesis of abdominal aortic aneurysm, whereas the other condition that is playing an important role in aortic aneurysm is hypertension. Now remember, hypertension is most important in case of ascending aortic aneurysm. Both atherosclerosis and hypertension are playing a role in aortic aneurysm, but atherosclerosis is more important in abdominal aortic aneurysm, whereas hypertension is playing a more important role in ascending aortic aneurysm. Now, what are some of the other causes of aneurysm which is leading to a weakening of the vessel wall? Advanced age, smoking, trauma, vasculitis, or congenital defects like fibromuscular dysplasia, okay, as well as congenital defects leading to Berry aneurysms in the circle of Willis. Okay, also infections like mycotic aneurysms, they can also lead to weakening of the vessel wall, ultimately leading to aortic aneurysm. Okay, so what are the causes? Remember, mycotic aneurysm can occur due to embolization of the septic embolus as an infective endocarditis, extension of adjacent suppurative process, okay, or as a circulating organism directly infecting the arterial wall. So this is how there can be infections of the vessel wall leading to weakening and mycotic aneurysm. So infections can lead to weakening of the vessel wall. The most common cause is staphylococcal infection, and most common site of mycotic aneurysm is the femoral artery. So these two are very important MCQs which can be asked in your exam. So all these, as you can appreciate over here, that aneurysms are most importantly related to the weakening of the vessel wall or weakening of the connective tissue or connective tissue weakness. So whenever you see such terms, think that they are speaking about aneurysm. So we have discussed the basics of the aneurysm and basic pathogenesis and the etiology. Now we are going to discuss a more specific form of aneurysm which can be asked directly in your exam, that is the abdominal aortic aneurysm. Okay, so aneurysm, it is a type of aneurysm due to atherosclerosis. Okay, so atherosclerosis due to aneurysm due to atherosclerosis most commonly occurs in the abdominal aortas and in the common iliac artery. Now, abdominal aortic aneurysm are most common in men as well as in smokers, and it is rare before 50 years of age. If you look at the morphology of abdominal aortic aneurysm, they are usually located between the renal artery and the bifurcation of the aorta. It can either be saccular or it can be fusiform. It is more than 3 centimeters in diameter, but most commonly if you see they are more than 5.5 centimeters in diameter, and they can be up to 25 centimeters in length. Severe complicated atherosclerosis with destruction and thinning of the underlying aortic media can be seen in abdominal aortic aneurysm. Aneurysms over here, they are frequently contain bland, poorly organized mural thrombus. So as we are, discussing about the morphology of abdominal aortic aneurysm, I hope you can recall the question in the first half of the video that I have discussed. Okay. So over here, very commonly in abdominal aortic aneurysm, you will see an associated atherosclerosis, you will see a dilatation, okay, you will see mural thrombus. Often the dilatation is more than 5 centimeter in diameter. Now, abdominal aortic aneurysm may be accompanied by small aneurysm of the iliac artery. So, abdominal aortic aneurysm may also be accompanied by small aneurysms of the iliac artery. So, this is mainly the abdominal aortic aneurysm, they are associated with atherosclerosis mainly. Okay. Now, having spoken about the abdominal aortic aneurysm, there are certain variants, okay, which need special mention. Number one is the inflammatory variant of abdominal aortic aneurysm, which constitutes 5 to 10% of all the cases of abdominal aortic aneurysm. It is involving younger patients, characterized by increase in the inflammatory marker like the ESR, associated with back pain, characterized by abundant lymphoplasmacytic inflammation with many macrophages, and associated with dense peri-aortic scarring. Now, basically it occurs due to localized immune response to the abdominal aortic wall. So, this is the first variant, that is the inflammatory variant of abdominal aortic aneurysm. Another variant is IgG4 related variant. Now, over here a subset of, now this is regarded as a subset of the inflammatory variant of abdominal aortic aneurysm. So, this is basically the vascular manifestation of IgG4 related disease. Okay, there is a high circulating levels of IgG4, storiform fibrosis and IgG4 positive plasma cells. It is important since it responds well to steroids and anti-B cell therapy. That is why it is important to recognize this variant. Now, host of other organs are also involved. Now, I am not going into the detail of IgG4 related disease. Already I have made a lecture on that, that is present in the website. Okay. Now, there can be associated retroperitoneal fibrosis as well as bilateral hydronephrosis in such patients. Okay. Thirdly, we can have mycotic abdominal aortic aneurysm. Over here, basically the abdominal aorta is infected by circulating microorganisms. Okay. Now, what follows after infection, there is suppuration which destroys the media, leading to weakening, and ultimately there is an aneurysm. Okay. So, this is about the abdominal aortic aneurysm. Now, we will look at the clinical features of abdominal aortic aneurysm. So, most of the cases of abdominal aortic aneurysms are completely asymptomatic, and they are discovered incidentally on physical examination as an abdominal mass, most often as a palpable pulsating mass that simulates a tumor. Now, what are the other clinical? So, most are asymptomatic. Okay, physically you can see the pulsations. Okay. Now, the other clinical manifestations, if there is a rupture into the peritoneal cavity or the retroperitoneal tissues, can lead to massive, potentially fatal hemorrhage. If it leads to obstruction, then there will be features of downstream ischemia. Okay. If there is an embolism, because there is a formation of thrombus, so it can embolize. Okay. From the atheroma or mural thrombus, and that embolus might lead to a massive stroke. Okay. Impingement on an adjacent structure, for example, compression of the ureter or erosion of the vertebra can be there. Now, remember, the risk of rupture is directly related to the size of aneurysm, varying from nil for abdominal aortic aneurysms less than equal to 4 centimeter in diameter to 1% per year for abdominal aortic aneurysm between 4 and 5 centimeter, 11% per year for abdominal aortic aneurysm between 5 and 6 centimeter, and 25% per year for aneurysm more than 6 centimeter. So, you should remember that this is very important from MCQ point of view. Most aneurysm expand at the rate of 0.2 to 0.3 centimeter per year, but 20% expand more rapidly. In general, remember, if an aneurysm is more than equal to 5 centimeter, then they should be managed aggressively, either via the open surgeries involving the prosthetic grafts or endovascular approaches through the femoral artery, deploying a stent graft. Okay. Timely surgery is critical. Operative mortality for unruptured aneurysm is approximately 5%, whereas emergency surgery after rupture carries a mortality rate of more than 50%. Okay. So, I hope this point is crystal clear for everyone. Okay. Now, very importantly, I would like to, just go back to the question, that the first question that we had discussed. Okay, let me just frame the question again. A 62-year-old man presents with a 2-week history of abdominal discomfort. So more or less they were asymptomatic. On physical examination, you can see the pulsatile abdominal mass in the periumbilical lesion. A CT scan is showing a segment of abdominal aorta which is approximately 5 cm dilated and calcified. So if you look at the age of the patient, look at the clinical symptom, basically just a discomfort was there. So they were asymptomatic. Look at the sign, okay, a pulsatile abdominal mass is there. Okay, then the CT scan is also showing that the size is nearly 5 cm and calcified, means it is an atherosclerotic mass. Okay, so all these are pointing towards atherosclerosis leading to abdominal aortic aneurysm. Okay, so basically this so the diagnosis is abdominal aortic aneurysm, but over here in the option you don't see this. So you have to see the most common cause of abdominal aortic aneurysm is atherosclerosis. Right? Now the abdominal aorta is examined at autopsy. Now what happened? The patient is scheduled for surgery because, as I told you, if it is 5 centimeters or more, then you have to go for surgery. But because this condition is also having a mural thrombus, okay, so there might be embolism and the embolus can go to any part. So in this case, basically the embolus went to the brain and led to massive stroke and the patient expired. Okay, so basically which of the following is the most likely underlying cause of the patient abdominal mass? So the first condition is you have to diagnose. It is a case of a abdominal aortic aneurysm. And basically what is the most common cause? Atherosclerosis. Remember, atherosclerosis. Now remember one thing, other points are there like angiosarcoma, they will not fit. Hypercalcemia, no, will not have this symptom. Thromboembolism, see over here there is a pulsatile abdominal mass. So thromboembolism is there, but it is not the first cause. The underlying cause is the abdominal aneurysm secondary to atherosclerosis. This is the correct answer over here that we have to know. Now remember, one more option over here is cystic medial necrosis. Remember, in cases of aneurysm of any type, we are using that microscopically, you will see cystic medial degeneration. But for aortic dissection, okay, usually we are using the term cystic medial necrosis. It is limited to aortic dissection. Remember, over here we had an aneurysm leading to a large mural thrombus embolizing to the brain, causing a massive stroke. So this was a case of an aneurysm, not an aortic dissection. So again, this will not be the answer. Okay, so the answer over here will be atherosclerosis. Okay, now let us see some more important MCQs. Let us throw light on more important MCQs. Okay, before we go to the MCQs, first we will see the thoracic artery aneurysm. Now they are most commonly associated with hypertension, although other causes such as Marfan syndrome, Loyal-Dietz syndrome, inflammatory conditions like aortitis are increasingly recognized. Now before dissection or rupture, symptoms can include chest pain from encroachment or erosion into the bone, myocardial ischemia from compression of a coronary artery, difficulty swallowing due to compression of the esophagus, hoarseness from irritation or from pressure on the recurrent laryngeal nerve, respiratory complications from compression of the bronchi. The vast majority of this aneurysm, they cause no symptom at all until a catastrophic event occurs. I would like to throw some light on syphilitic aneurysm, and there is an important question based on that. This is also known as lutic aneurysm. It is seen in tertiary state of syphilis. The most common site is the ascending aorta for syphilis. Okay, most commonly they are involved in the tertiary stage of syphilis. Linear calcification of the ascending aorta is characteristic feature. Microscopic examination will characteristically show obliterative end arteritis of the vasa vasorum. It causes focal necrosis and scarring of the media. The inner surface of the affected aorta shows a characteristic tree bark appearance. Okay, very important MCQ. Now we will see some of the important MCQs if they ask you such MCQs. The most common cause of aortic aneurysm overall, or the most common cause of descending aortic aneurysm. Okay, in other words, they are saying abdominal aortic aneurysm, or the most common cause of abdominal aortic aneurysm, or the most common cause of aortic arch aneurysm. Then the answer is a single one, that is atherosclerosis. If the question is most common cause of peripheral vessel aneurysm, okay, most common cause or most commonly which peripheral vessel aneurysm is there, it is popliteal artery. So the most common site of peripheral vessel aneurysm, the answer is popliteal artery. Now, as we have discussed this point, this was the first half of the lecture. Now we are going to discuss about the aortic dissection. Sometimes aortic